Hello, my name is Laura Zahardine, and I am a project coordinator at the Provincial Council for Maternal and Child Health, later on referred to as PCMCH, and I will be helping and facilitating this webinar today. I would like to welcome everyone to the webinar this afternoon. The presentation will commence shortly. A few housekeeping items. Your microphone should already be muted. If not, please mute it by clicking the microphone icon. Also, your video feed should already be stopped. If not, please click the camera icon to disable. Participants will be able to ask questions at the end of the webinar. You will see below a Q&A tab when it is available during the discussion period. If you experience any technical difficulties throughout the webinar, please refer to the instructions attached in the email or contact Carla at carla.santos@pcmch.on.ca. A reminder that all the resources presented today are accessible online on our website at www.pcmch.on.ca. I will now begin the Neonatal Follow-Up Implementation webinar presented by Dr. Paige Church and Dr. Vincent Ho. Dr. Church is a co-chair on the Neonatal Follow-Up Implementation Work Group at PCMCH, as well as a medical director of neonatal follow-up at Sunnybrook Health Sciences. Dr. Ho is also a co-chair on the Neonatal Follow-Up Implementation Work Group at PCMCH, as well as a medical director of the NICU and Neonatal Follow-Up Clinic at the Royal Victoria Regional Health Centre. I will now pass it over to them to begin the presentation.
Hello, and welcome and thank you for joining us on this webinar. Before we begin, Paige and I want to take this opportunity to thank everyone who has contributed their expertise, time, energy, and passion to the culmination of work that we have the pleasure of presenting today. It is a large undertaking and could not have gone this far without you. Thank you. And thank you for everybody for joining in on this presentation. Today's agenda, we're going to look at a quick case study, which we will revisit down at the end of the presentation, or near the end of the presentation. Give you a little bit of background about how this work all came about, and we will quickly review the Neonatal Follow-Up Program recommendations that came out of the first part of the work. In the second part of the work, we developed tools and resources, including tools that the clinics can use, communication tools between clinics and with the community at large, and looking at some of the system considerations that we discussed and are considering as ongoing work as well. And then we'll have time for a little bit of discussion at the end. So this baby doesn't exist, but is a example of a baby that we often see. Jessica is a 33-year-old primip who had P-prom at 28 weeks gestation and spontaneously went into preterm labor at 29 weeks. She delivered a baby boy who weighed 1,100 grams. Tommy was admitted to the NICU as he needed respiratory support via non-invasive CPAP, gavage feeds, and intensive care monitoring. He was eligible for discharge at 36 weeks. I want you to think about what type of follow-up Tommy is eligible for. So neonatal follow-up, since its inception, has evolved quite dramatically. In fact, in the early days, intervention was frowned upon because of concern of the impact that would have on the true results of neonatal care. Historically, neonatal follow-up evaluated the impact of care for infants in neonatal intensive care units. This research focus continues on, but the role has expanded quite considerably. We now, because of knowing that early intervention makes a big difference on ultimate outcomes, we've now added monitoring and early intervention to promote the optimal outcomes in these high-risk infants. So for the 2013-2014 fiscal year, there are 24 identified neonatal follow-up clinics in Ontario. The majority of these clinics are located in LIN 7, 8, and 9, and each having 6, 4, and 4 neonatal follow-up clinics in their LIN respectively. A new neonatal follow-up clinic at Markham Stouffville Hospital in Lynn 9 opened in 2014-2015. In November 2013, the Provincial Council for Maternal and Child Health, PCMCH, convened the Neonatal Follow-Up Clinics Work Group. Their objectives were to examine the current state of neonatal follow-up in the province and make recommendations to best address the needs of the population. From this work, 9 recommendations were developed.
Great, thank you. Hi, it's Paige Church, and I just wanted to say, as I looked at the list of participants, so many of you worked on this, and again, we just want to say thank you, because this is your work as much as anyone's. So the recommendations that were generated from the work group include that overall, one of the big ones was that we really wanted to think of neonatal follow-up as a bigger system within Ontario, rather than each clinic operating independently, that there was a network that was collaboratively working in Ontario, and it was comprised of the individual neonatal follow-up clinics working together to provide service to the high-risk infants from NICUs. The program as a whole has common goals, and with these recommendations we set forward a visit schedule that was harmonized, and wanted to articulate as well that the clinics were not, but also going forward, did not want to work in a silo. So the first recommendation was really just to simplify who gets follow-up when and by who. And this was something that actually came out of the Provincial Council, Executive Director's assistance, but really just pairing levels of care that you receive as an NICU infant with levels of care that you're eligible for follow-up. So for example, if you are deemed a level 3 infant due to your acuity, then really you should be deemed a level 3 infant for follow-up due to the acuity of the neonatal course. For babies that were deemed low risk in level 1 or level 2A NICU or special care nurseries, that was felt, while of course we want all babies to have something, we felt that that could be done by primary care or a community pediatrician. The second recommendation, and this was one that came out of even the model of how the co-chairs were set up with level 3 and level 2 with Vince and myself, was the idea of a shared care model that should be implemented across the follow-up program. I don't know if you want to, Vince is going to talk about this.
So this is a very important part of the whole neonatal follow-up program. It addresses the need for providing care close to home, especially for those centers that are far away from the tertiary centers geographically. And so it optimizes and emphasizes the communication between the level 2, level 3 units, so that these babies will not fall through the cracks and will be cared for by the program in general. And even in the short period of time from the implementation of these recommendations to present, we're still working through a few of the bumps and valleys of this system, but the bottom line that seems to be very strong is the communication being the most important factor.
And ideally, the shared care really is to take advantage of resources that are closer to home, and also make sure that the level 3 clinic gets outcome data, but also can offer what other additional resources they may have. The caveat is that shared care really was intended for those communities that are not as proximal to the GTA. So for example, Barrie, Sudbury. If there is a level 3 clinic nearby, then shared care would not be the model that we would recommend, right? Yes. So the third recommendation is that really wanted to set up a schedule of visits that was standardized. And instead of it being because it works for this administration to do it this way, or because it was convenient for a team to see babies based on this schedule, we really said, what do the families need? And that should be the driver of when the visit schedule should happen. So it's based around the concept of touch points, which is from T. Barry Brazelton, and it describes a moment where the infant and the family may have a moment of struggle or conflict or stress, and that's really what should drive our assessment schedule, and not other things. The assessment tools that were selected, really we decided to put forward a whole battery of opportunities that people could use based on their local resources that were available, and then they could apply them to that specific touch point. So, for example, one of the recommendations is that babies and their mothers be seen at 6 weeks. And the identified touch point that really needed to be attended to was to make sure that maternal mental health was okay. And so we put forward different measures to screen for that, mainly the Edinburgh, but there are others. The fourth recommendation was really around clarity as to what the Neonatal Follow-Up Program does. And we did this mainly because we were working beyond just our own clinics at the table. We also had community partners with early intervention, treatment centers, different participants that we work very collaboratively with in our communities. And what we wanted to clarify is that the Neonatal Follow-Up Program is mainly providing intervention in the form of parental and family coaching, teaching them to be self-advocates, as well as intervention in the form of linking them to community resources, providing referrals if needed, and helping them with resource navigation and education. So you can see that triangle, sort of the base of the triangle is really what the Neonatal Follow-Up Program is providing, that coaching and general information. A tier 2 might be a referral to a community resource for more one-on-one intervention, and then obviously a tier 3 might be one-on-one ongoing assistance with a treatment center. And you can see that as the triangle goes up, less and less children need that level of intensity. The fifth recommendation was that we recognize that that while these recommendations are important, it's also important that we can measure them or look at them. And so we recommended that data collection should occur, and with this harmonized schedule, it would make it easier to collect consistent data because we would all be measuring similar events, not necessarily with the same tool, but using standardized assessment tools. And we did recommend that a committee of experts should come together, and that should include Born Ontario, as well as the Canadian Neonatal Follow-Up Network, to look at the touch points and decide where and how they wanted to collect data. The sixth recommendation was to create an online forum for ongoing communication, collaboration, and education amongst the program so that individual clinic providers and participants in their individual clinics could benefit from the program as a system and know what opportunities for education were out there. It also ideally is a place where we can post questions not specific to a patient, but questions about different assessments or training opportunities, things like that. Central to that is a central contact list so that it's easy for people to collaborate and share information or talk about patients as they move around with shared care or they may move within the province, and then also educational materials. Moving out now to a system recommendation, so no longer within the specific follow-up clinics themselves or the program, but now how as a program we would recommend that the program operates within the bigger system, is that we all collectively agreed and heard that children in the follow-up programs need to have established successful school transition plans. That may include follow-up into the school years if it's available and if it's warranted. It may not be the same format across the province. For some clinics, they have great partnerships with their local early intervention group, and that local early intervention group takes that transition on and does it. But what we felt strongly about was that collectively these children need support beyond just the first couple of years. The eighth recommendation, again, was a system recommendation, and this was around school enrollment. So what we recommended was that children born technically premature, so anything less than 37 weeks, and born in one calendar year but due in the next calendar year, that school enrollment should include parental input. So currently, many of the schools, it's based on their birthday and there's no discussion, and we recommended strongly that parents than anyone and could advocate for their child to enter based on their due date if they felt that that was best for their child. We also recommended in our ninth recommendation that there be linkages established between the follow-up program and the Ministry of Education, because we have heard far too often from our families how stressful and how difficult that transition is. And there certainly is now emerging evidence that the school system is ill-prepared for them. So we felt strongly that we needed to establish a linkage with the Ministry of Education to share our information and to help work to create programs and/or interventions that would help the schools and help the children succeed in school.
So in 2015, after the recommendations came out, we convened together an implementation work group. And this was to develop an implementation strategy for the recommendations of the original follow-up group. The goals of the implementation work group were to reduce the variability of practice amongst the neonatal follow-up program clinics and align standards unifying the system as a single program. Create a strategy and implement the clinic recommendations in collaboration with neonatal follow-up program clinics. Create a strategy and implement the broader system recommendations in collaboration with the neonatal follow-up program clinics, and develop an evaluation framework with indicators to assess the process and impact of applying the recommendations. So our biggest concept is that the neonatal follow-up program should be part of a larger provincial collaborative system. So not only itself being a program of the clinics together, but that being a bigger part of the whole system treating children. They don't operate in silos, and that was one of our goals. The ultimate goal was to place the families at the center of care by developing a cohesive system of neonatal follow-up that includes collaboration amongst the clinics and other relevant care providers. We're hoping by doing that we could leverage some resources and pool the resources together, standardizing key functions and providing equitable access to high-quality care.
So one of the things we worked very hard on is developing tools for the follow-up program for the individual clinics. Because when we all got at the table, there were so many great things that individually were being used at one program but not the next, and we really felt like we wanted to sort of harmonize that and take advantage of opportunities that existed to better everybody and make everybody feel stronger and more empowered. So the next thing we're going to go through is there's a list of tool assessments or different assessment tools and who can use them and how, and we'll go through that. Screening forms, a shared care form, the levels of follow-up. There's a reference sheet just in case it's all confusing, and then we did do some diagrams mainly to just demonstrate what happens to our patients go through the system. So, want me to do this one?
Sure.
Okay. One of the things that we really were struck by when we were at the table was that, and one of the goals, I think quite frankly up front from the initial meeting, was that we would all use the same assessment tools for every assessment. And what we very quickly realized is that it would have devalued individual clinics far too much. And by that I mean that every clinic was operating with incredible passion, with incredible people, but not every clinic had the same different team members. So some clinics have speech therapy, others don't. Some clinics have physiotherapy, others might have occupational therapy. And we were very concerned that if we mandated that a certain assessment was the one that had to be done, that we would limit who could do it and stress clinics in a way that was unnecessary and quite frankly lose a lot of the strength that the individual clinics were operating with. So instead, by setting up the harmonized schedule where each visit has a goal and a touch point, we then felt if we provided a list of assessment tools with the goal of what that assessment tool can measure, individual clinics can say, we have this strength, this assessment tool fits that, and we can move forward with that. So the list of assessment tools was really every assessment or developmental assessment we could think of that might come up as a possibility, who can do it, how long it takes, what level of training is required, and then it empowers individual clinics to say, this is the right tool for us, this works for our team.
I think also the worry that we came across was that because there isn't one single tool that's best for every domain of development, a great assessment or assessment tool in the hands of a therapist who isn't familiar with that tool is actually potentially more dangerous than somebody using an assessment that they're much more familiar with. Postnatal screening forms. One of the things that came out in our discussions and deliberations was that there's little emphasis on how the family is doing as a whole. The focus is always on the baby, and with postpartum depression being as prevalent as it is, it became necessary that this was when neonatal follow-up program clinics were seeing the families. It was at a critical point shortly after they were discharged from the NICU, where postpartum depression may be much more prevalent. So screening forms were developed, or not developed, but were collected to help identify some of these high-risk areas. The issue was that some of these tools, although they're very good and validated, may not be applicable to all populations, such as fathers or same-sex couples, those sorts of things, different circumstances. But nonetheless, it raised the idea that we needed to address the family's mental health at the time of these neonatal follow-up clinic visits. Okay. Now, the shared care form is a form that hopefully facilitates communication between the level 2s and level 3s. It's meant to be a form that is developed or filled in at the time before baby's actually discharged from the NICU, usually from a level 2 NICU at that point. And the tick boxes that say level 2 or level 3 will help identify which appointments are being attended to at which site. And the point is for the parents to be able to sign this form, the level 2 site and the level 3 sites to be able to sign the forms, and fax back and forth so that everybody knows exactly which visits are being attended to and where they're being attended to. This hopefully clarifies it, and then the intention is for this shared care form to be faxed back and forth following every visit with potential comments and concerns raised in the box at the furthest to the right, so that the communication is simplified. That doesn't preclude sending the actual assessment forms or assessment notes from the visit, but it just helps highlight it so that perhaps even discussion verbally on the phone between two clinics can happen spurred by that.
And then just because, well, it's easy and great to say levels of care should be paired, everybody knows that there's the child that ends up in their nursery that doesn't necessarily meet their nursery's requirements, but it might be that there's a bed issue and we can't move the child, or the child is sick for about 15 minutes, but then there's nowhere for the baby to go. So while we do think overall levels of care should match, we also created references for really where that should sugar out in case there is some question that a child does not necessarily meet criteria to be in whatever NICU they are. So this reference sheet is helpful for, administrative people who are booking the appointment, that they can sort of refer back to it, or other people on the team just to sort of check and make sure that they know which level of care the child appropriately meets. I think some sentinel changes that were made were that level 3 now extended itself to follow up until 29 and 6/7 weeks. So up until 30 weeks would be considered a level 3 baby with a weight criteria of ballpark of 1250. So if they were 30 weeks or 31 weeks but weighed 800 grams, they still might fall into level 3 criteria. And level 2 extended itself until 33 and 6. And this is a huge undertaking to take that many more babies, but that was based on the emerging evidence that these moderate preterms really can have developmental struggles and would benefit tremendously from being enrolled in a program. And then at the request of different partners in the community and also the provincial council, there was a question about, well, what happens to these children as they go through the system? Where do they end up? And so these flow charts are really a descriptive way of trying to show how our children may navigate through the system. And they may be helpful if you're trying to demonstrate it for an administrator or someone who may not be as inherently aware of our patients and our patients' populations. But we generated one for children who had motor concerns, social concerns, cognitive concerns, and they're all on the website. Yep.
So again, it all comes down to communication. And what we realized in going through this whole process is that even many of the providers out in the community are unaware of what neonatal follow-up programs are and what we can provide as a neonatal follow-up program. So we endeavored to set up a set of communication tools, mainly letters, to addressing the different groups, one being to the healthcare providers and physicians in the community, again, describing what neonatal follow-up program is all about and what our target population is and what services we can provide. An information package for parents and families. Most centers did have their own information packages, but this unified and consolidated a lot of those information packages. For example, one of the things that we found that was lacking was that parents may bring their baby in their first visit to the neonatal follow-up program and be surprised that they're being asked about the maternal mental health or the parental mental health, because they thought they were bringing just their baby to the clinic. And so this information package addresses that in terms of saying that we are interested in how the family is doing as a whole, and we'll be asking questions about that so that they aren't surprised. There's also a brochure about the neonatal follow-up program in general that we hand out to parents as well. The visit schedule poster, which I think is one of our big accomplishments, is unifying and trying to standardize the visits according to developmental touch points. And then a graduation letter that doesn't mean that we're dropping them off, but just helping the kids move on and transition into their next stage of life, which often may be just preschool or into school itself. This is a copy of the letter of the providers. I'll just sort of quickly go through these. I won't go through in any detail. We've got the information package for parents. Again, all of these are available on the PCMCH website. The brochure for parents and families, which can be customized to the individual institution by changing filling in the logo spot and making a few adjustments as necessary. And then our visit schedule poster.
And sorry, really we jumped sort of at this stuff. We had a lot of feedback on the implementation committee and on the recommendation committee were parents. And so they felt strongly that if they were empowered and educated into what they should be getting, that they too could self-advocate. And so, a lot of these are also for parents, but also so parents will know what they can expect. No? Oh, the graduation letter. That's a nice one.
Okay.
And I mean, we really took advantage of other clinics' resources and tried to offer them to everybody. It was very clear at the initial recommendations group and then the implementation group that everyone is operating on a shoestring budget with incredible passion. And so what was really neat to see is that passion comes a lot of hard work, and people were very willing to share their hard work so that other people could benefit from it, and then we would start to move forward more effectively. So the graduation letter came out of different clinics, different letters, and we generated one that can again be individualized so that it's appropriate for your institution.
The next one is the referral form, which we thought would just be helpful in reminding people or referees what the criteria are for the specific level 2 or level 3 neonatal follow-up program clinics. And it's a very generalized form. And there's also a form that if there is a concern by the physician, that a referral can be made based on the discretion of the healthcare provider or primary care provider. But these are reminders of the eligibility criteria as well. Coming back to baby boy Tommy, So we put the slide up again at the end here to remind everybody exactly who we were talking about again. 29-week baby who's 1,100 grams at birth. And we have a polling slide next to for you to put in your answers, if you can, about where you think this baby is eligible to follow up.
With 76% thinking level 3, 24% saying level 2, and no one chose any other option. So Paige or Vince, do you want to share the answer and a little bit of why?
So this is, I guess, a bit of a trick question in a sense, of course, like everything else. Certainly this baby, having been born at 29 weeks, qualifies for level 3. But certainly, so that the baby does not fall through the cracks, level 2 with a shared care with level 3 is also a very appropriate answer as well. No follow-up is needed is not appropriate. Certainly follow-up with a pediatrician, especially in an area where there is very difficult to access neonatal follow-up program clinics, may be the only option available, but certainly we need some kind of follow-up. But certainly, more ideally, first and second answers would be most appropriate.
Yeah. So some things to consider as we kind of move forward, and some important things to be aware of is that if you are in Toronto, the Toronto District School Board is now, prior to our recommendation, so it has nothing, as much as I want to think that we created change, the TDSB in and of itself now considers parent input when they consider registration. Unfortunately, that is the only school that I know of in Ontario that is doing that. We have not yet established a link with the Ministry of Education, but we are. We're currently drafting the letter. And there is solid evidence that there is a lack of awareness in schools by the staff of the challenges and what to anticipate. And that evidence is international, but also local evidence. So that's important to bring forward to them. And also moving forward, we need to make sure parents have education themselves so that they can themselves be the most effective advocates. The network, collaborative, I always need more teaching. And schools, if possible, we still need to work on educating them, and we have not crossed those bridges yet. In terms of data collection, the discussion, we did start a discussion with Bourne and CN Fund, and that is slowly moving forward to look at what variables and how to effectively move this forward. We know that there's a tremendous amount of data in Ontario amongst these clinics, and it's just really how to do it so it doesn't generate a lot of work for people, and yet it can generate a lot of important information. Obviously, we so desperately want ongoing collaboration between the different clinics within the program, and what we're hoping is that a basic footprint has been established by using this harmonized schedule of visits for research questions moving forward.
Okay, so we will move on to the discussion period. Just give me a second to set this up. So we'll now begin the Q&A session where you can send questions to the presenters. Only you and the presenters will be able to see all your questions and not other attendees. If you do choose to ask a question, we would like you to enter your name and/or center in the start of your question. For this webinar, all questions will be answered verbally by the presenter. And you should see the Q&A tab has popped up on the bottom of your screen. We're just waiting for someone to start us off here with a question. So we have a question from Jamie. For the mental health screeners, will screening be mandated?
So I think it's important to recognize that in no way, shape, or form do these recommendations have any authority or penalties associated if you're not doing it. What we were asked to do is to put forward what we thought was, within some degree of feasibility, the best opportunities for Ontario families. And with that comes that we felt strongly that at a visit at 4 to 6 to 8 weeks post-term, it was very important to ask parents how their mental health was, recognizing that an NICU experience has a much higher rate of depression and anxiety. The screeners we put forward are very, very, very easy to use. They require essentially no training. Parents can self-complete them, and they are not time-consuming in the clinic. So we would recommend considering them, but there's no absolute that you have to use these screeners themselves, but it is an important conversation to think about having.
Okay. We have another question from Marika Beaumont. The team is very worried about the gap between 18 and 36 months in the
On attrition rates. So yeah, so the question is about the gap between 18 and 36 months and what that will do to attrition. And we don't disagree with you, but we were also hearing very loudly and very clearly from our individual clinics within the program that that adding visits would be almost impossible at these later ages from a resource standpoint, and that early intervention and our other community resources that were also at the table felt that they by then were more involved and were providing some assistance. And further to that was that between 18 months and 2, because that was the big debate, do we move the 18-month visit to 2 because then the gap between 2 and 3 is shorter? And we left it at 18 months because collectively the clinics at the table, which was almost every representation from every clinic, was that it was too essential to look for social skills and communication skills, and specifically around autism, and to wait until 2 to identify and intervene felt too long. So the visit was left very specifically at 18 months.
I think it also stems from the fact that, again, as we said, this isn't mandated, but it doesn't preclude any individual follow-up program clinic to implement a visit in between if they were worried about that particular child. And that doesn't necessarily only mean the 2-year, but it might be at any stage of the a course of the neonatal follow-up program follow-up, where a baby might identify some risk factors and may need to be followed up more closely.
Sorry, another question just to acknowledge it was around the special needs strategy, and we have initiated some discussion. It's still in the process. I think the special needs strategy is also still sort of hammering through its implementation, so I would imagine at some point we will have some potential crossover.
So we have a question from Trillium, Credit Valley. Why did you choose 3 years as the final visit rather than the 2-year visit that many clinics are using?
Where do you want me to go? So I think one of the reasons was we felt very strongly that that at 18 months we really wanted to see the children and look at their social skills, their communication skills, identify concerns around autism specifically, and that 2 felt a little bit quick to be following up. So the 3-year visit became the one that collectively people felt was more feasible. It also gets us closer to school, lets us have the discussion around transition to school, and to the families it felt more real. A lot of the input from the families at the table was that at 2, they were just clearing the hurdles of concern for their child having significant challenges or having something that they were concerned about that would pose more significant resource needs, and that they weren't quite ready to focus on the transition to school yet. So those were the reasons we elected to push it out.
Okay, we have a question from North York General. Is the vision for mental health screening to refer to public health resources if there's a positive screen?
So this has been a definite worry when we first made the recommendation, because again, when you have a positive screen, what do you do with it became the prominent question. And certainly it's referring to public health resources and referring to the primary care provider was the mode that we felt was most effective in terms of dealing with a positive screen. Certainly if there was high-risk concerns such as suicidal ideation or something like that, then that would need an emergent visit to the emergency department.
Yeah, I mean, you guys just started, you've been doing this in the last year, and...
Well, we haven't done formal, but we have been asking questions regarding it since the recommendations. And We actually are lucky. We have a social worker who's in the clinic next door, which is the diabetes clinic, and so we have been able to pull from her if we ran into a positive screen, or we would a more urgent positive screen. Otherwise, we would go through community resources.
Yeah, and I can also speak from Sunnybrook, our experience, and I can tell you that there was a lot of angst about us starting the Edinburgh from the whole women and babies team, and we have found that it is an essential component now to our schedule of visits. The conversations end up being so much richer and so much broader with the parents than they ever were before. I have yet, knock on wood, in 2 to 3 years of using this, we have yet to refer to the emergency room for any suicidal ideation. Almost any positive screen, all we've done is taken the mom's health card herself, taken a Xerox of it, and called her family doctor, and they have been amazing team members at picking it up and taking it over. It literally has been seamless. So I think a lot of the angst is not necessarily proving to be real.
So we have another question from Randy. How would the harmonized schedule, the extra visits for some clinics, be funded?
When we initially had our intake, or we did a survey initially of the province and what resources were available, and there was inconsistency around the province as to how individual clinics were operating financially. Some were doing it as part of the hospital's global budget. Others were doing it with physicians billing for their time with the Ministry of Health. So I don't think we have a specific answer as to how individual clinics are going to self-fund these recommendations, but we were asked to put forward what individual clinics can then advocate to their hospital administrators to say this is what is considered the standard of care in Ontario, and then let the hospital administrators determine how they're going to fund it.
Okay, we have a question from Glenn. Was a comprehensive environmental scan completed to understand the true needs of neonatal follow-up in the GTA?
Yes, so we did one, what year was that, Doreen? 2013? Yes. Through all the clinics in Ontario and all the hospital administrators, like it was sent very globally.
Results from that environmental scan can be found in the report that's on our website. Laura will give you the, right, she's just taking it up right now.
There's a lot of questions. Well, that doesn't matter if I say it out loud because they can't hear it. There's people who apparently can't hear it, and it will be uploaded on the website. They can't hear that, though.
So I have a question from Audra. Please provide a more detailed definition of the shared care model, the Bailey at the 36 months, that will be at tertiary or level 2 neonatal follow-up clinics.
So this is one of those things that's in transition. For the way Paige and I have worked it through in our shared care models has been the baby would go to the Sunnybrook for the 18-month visit, and to have the Bailey done at that point. We also have discussions about possibility of Bailey being done locally, either by our infant development program or our or actually a joint session with the Sunnybrook team, but none of that has really been finalized or even really gone beyond the conceptual stage. Yeah.
So Audra, I think it's somewhat based on whichever center the shared care is with, what resources they have, what they can contribute, what they want to contribute. If a level 2 has the capacity to do a Bailey, I'm willing to have that discussion to say great. We only really recommended the Bailey at 18 months for the level 3 centers in order to continue to collaborate with the Canadian Neonatal Follow-Up Network. There isn't necessarily a recommendation specifically that the Bailey has to be done at 3. Instead, the touch point is really around behavior management and preparing for school is the ideal touch point. So it may not even be relevant to be necessary to do a Bailey at 3 if there's a shared care model between the level 3 and the level 2.
Okay, we have another question from Trillium Credit Valley. The referral form seems to be missing many referral criteria for the regional programs. Are children under 2,000 grams all being seen still? What about seizures in NES babies? And can you clarify the neonatal acidosis criteria, APGARs, and or code corn pH?
Well, one thing I know we tried to do was we tried to move away from a birth weight criteria and move more towards a gestational age, because that is more in keeping with where the literature has gone, that it's more reflective of the possibility for difficulty or dysmaturation. So yes, there are still some weight criteria, like for example level 3, but that really was to capture the additional data on a very small baby having the additional stress of intrauterine growth restriction as an added stressor. In terms of, sorry, I have to look back. What about seizures in NAS babies?
Well, I think for seizure babies, they often are followed up in the neonatal follow-up clinics, as well as the neonatal absence syndrome babies who require pharmacological therapy.
I mean, the general principle still goes back to, if the baby has a seizure and is in a level 3 center requiring level 3 level of assessment and intervention, then that baby should have level 3 follow-up. If the baby has a seizure and he's in a level 1 nursery and never advances to a level 2 or a level 3, then likely whatever was the etiology of the seizure never contributed to any significant developmental risk. We realize that there may be some gaps, but if there aren't specifics, and that's why we moved away from nitpicking every single detail on the referral form and getting back to, if it's a level 3 baby, it's a level 3 follow-up. If it's a level 2B baby, it's a level 2 follow-up, to sort of try to catch the babies that we couldn't necessarily come up with every permutation of what could go wrong that might make them mandated for follow-up. I hope that makes sense. Does that make sense? Yeah.
We have a question from Marika. We don't see families that early at 4 to 8 weeks. Could we mail out the screen?
I don't see why not. I mean, the recommendations, and it was interesting, like, for example, Ottawa, I think, is also choosing to have that visit be a partnership with their public health nursing team. I'm hoping I'm reflecting that right. I see Carol as one of the participants, so I'm sure she'll text me or tell me if that's not correct. But different hospitals are implementing that in different ways. And if there is a strong resource that you have in your local area with public health nurses to help you handle that positive screen, then that may be a very effective way to implement that recommendation. But at the core of it was that we felt that the dialogue had to be started between the parent and the follow-up team as to how they were doing emotionally. It may be that you only bring back the parents that are concerning and screening positive, screening above a 10 or a 9, for example. But we didn't have a specific mandate that it had to be done in a specific way. So I think that's not unreasonable.
And further to that point, the dialogue, I think, needs to happen back in the NICU as well.
Yes.
And discussion about this is what to expect when you come to neonatal follow-up clinic, but not only that, but also to see how they are doing as babies being discharged, because they're often quite frightened.
Okay, so we have a question from North York General. What is the expectation for level 2 clinics in terms of the motor assessment at 4 to 6 weeks of age?
So the touch point really is focusing on mental health for parents. We don't really have a specific touch point around motor assessment because we really felt that we wanted to emphasize that the visit should be around checking on mom and making sure that mom and baby are okay. If mom is clinically depressed and catatonic, everything we're going to do in our visits following that is going to be for nothing because we're building on a weak foundation that doesn't necessarily have the healthiest of attachments. So if you were going to do a motor assessment, it would be very specific to the different team members you have there, the resources you have in terms of training, and then there's a whole list of tools. I will say that the Journal of American Medical Association Pediatrics did put out recommendations for early surveillance for cerebral palsy just this past summer, and they do recommend the assessment of general movements as their gold standard. We did not necessarily mandate that that had to be done at 6 weeks, however.
Okay, we have another question from North York General. Is there any opportunity for support on training for the new or different assessment tools being recommended or proposed?
I love that question, and you North Yorkers, you keep asking them. So I would love to think that there could be an opportunity for training. One of the things that we have been talking about is trying to put together a conference that could be held every other year, and that's still a discussion. But immediately, first of all, we were very careful. We did not put forward specific recommended assessment tools because we wanted people to focus on the touch point, not the tool. So there isn't an absolute tool that has to be done. If in regards to the JAMA pediatric recommendations, which I think are very important, written by some of the best individuals around cerebral palsy identification that exist, the general movements is very interesting, and we are looking at having a local training course in the next year, but there are also some in the US, usually in Chicago and sometimes in Portland, Maine. And I've heard of one as well in wherever nationwide is for Ohio. So I think it might be Cleveland or Columbus, I can't remember. And I believe that one is sometime over the summer. So there are several opportunities if that's the tool that you're asking about.
Okay, our next question is from Audra at William Osler. Is there any plan to perform a transition pilot with the school systems to assess effectiveness or opportunities for education follow-up or school-age follow-ups?
Oh my God, this is so up my alley. Not specifically yet. I just I'm just in the process of preparing it for submission. We interviewed teachers around what they knew about prematurity and how comfortable they felt, and the data that we generated from largely around the GTA was that there was a huge knowledge gap. When I met with the school district boards prior to the research and was told that they would not endorse the research on a system level, the answer I got back was that I couldn't put forward any education opportunities or transition goal planning until I had documented that there was a knowledge gap. But then the school systems didn't want to identify a knowledge gap because they didn't have resources to fix it. So you can see where this became a bit of a circle that wasn't ending. We now have the data thanks to families in follow-up and families through the Canadian Premature Babies Foundation. And I'm hoping to move forward with that with a letter to the Ministry of Education that we're preparing now to ask them to meet us at the table to talk about how we can move this forward and prevent this from being an issue.
Okay, so we have a question from Tanya. Would it be worth creating a letter or document as a resource to parents to share with schools regarding preterm need?
That's a great question. I can tell you that we didn't generate that at our implementation group, and it was mainly, I don't think it was intentional, it was more of an oversight. At Sunnybrook, we have launched a website, and there is a letter that is downloadable on that because we only thought of it in the last year or so, and this committee had sort of already wrapped up its work. And that is easy to go to Sunnybrook's website. You can download it. Parents can put in their own child's information, and there's two letters. One is for any parent of any prem to put forward to the school, this is my child, this is how early they were born. These are the areas my child's really strong, and these are the areas my child might find really stressful, and these are how I deal with these situations, so that schools can be better prepared. The other letter that's downloadable is one that is for children born in the fall of one calendar year but due in the spring of the other, and self-advocating for delayed enrollment, and they just have to fill in their child's name and the principal's name and submit it. So those are both unfortunately linked at Sunnybrook, but we have links back and forth to the Provincial Council website as well.
Okay, we have a question from Catherine. She's an allied healthcare professional working on a team that follows these children. She said she's heard comments about how general the Bailey, two-part question, Bailey question, and she wants to know concerns that the Bailey is a screen and that it overestimates children's function in comparison to assessments done by disciplines. Little incomplete question.
So I'm not sure I understand it completely, but the Bailey is not a screener. It's a full assessment of children's development, and I agree with you. It does run the risk of overestimating, and it is a composite or a global assessment, so it doesn't take deep dives into the different domains for sure. And as a result, you may very quickly gloss over issues that are significant. The only place the Bailey was recommended was in tertiary centers for children under 30 weeks in order to continue to have the opportunity to collaborate at a national level with our outcome data, because this is the international precedent that's been set for how the international data is collected. It isn't something necessarily that I would recommend be done otherwise. Further to that, I can't remember what the second part of it was. Oh, it does run the risk of overestimating because the normative population for the Bailey 3 included children who have disabilities, so definitely there is a discrepancy between previous iterations of the Bailey and the current one, and that also has to be accounted for.
So North York has a question. In terms of the continuity of communication, is there an opportunity to leverage ECHN, care plans, and documents as a shared and accessible platform for all teams and providers?
That's a brilliant question. Are you guys on ECHN?
We are on ECHN.
We're not. I don't think it's an unreasonable thought or request. I don't know how necessarily to move that forward, but I think it's excellent and a great thought.
Okay, just because time is limited, we're going to have this last question from Audra. When do we implement the touch points to support the new model? Also, is there a PCMCH approach to support ongoing model integration and evaluation as we transition?
So in terms of when we implement the touch points, our recommendations were really starting after discharge. We didn't go near the NICU care, but after discharge, we recommended that the first touch point was between 4 and 8 weeks post-term, and that was to look at maternal mental health. And then onwards from there, each visit age that's in the presentation had a specific touch point to focus on. Those can be implemented now, any day. I mean, Vince, you've started to implement them. We've been implementing them at Sunnybrook for quite a while. So that should be able to happen immediately. And then as far as the PCMCH approach to support ongoing model integration and evaluation, we are working on that with the Maternal and Newborn Advisory Council and the Provincial Council to look at resources for looking at evaluation and measuring it.
Perfect. Okay, thank you guys so much. Thank you for attending our webinar. That's all the time we have today. Just to let you know, a recording of this webinar will be posted on the PCMCH website in the coming weeks. The documents and tools discussed in this webinar are live on the website and are available for downloading at www.pcmch.on.ca. Also, your feedback is important to us. We will be sending a post-event evaluation form via email. If you do have any further questions, please do not hesitate to email us at info@pcmch.on.ca. Thanks again.